All right, well, it looks like we're hitting a steady state on the attendee list. Thanks for joining this morning. Happy Friday. Really excited. This is the first time we're doing a Spectrum PHS Pilot Projects Symposium. And I want to first of all start by thanking Spectrum. So if you're from the medical school, you're, I'm sure, very familiar with Spectrum, but since we're a very interdisciplinary group with folks from across the university, I just want to mention a little bit about Spectrum, and they're an organization. If you have any interest in health, especially health in the community and population health, it's an organization worth looking into. So Spectrum is the Stanford Center for Clinical and Translational Research and Education, and it's led by our Dean of Research, Ruth O'Hara. And we are part of the funding for this program comes from Spectrum. So what Spectrum is about is translational research from bench to, which traditionally was bench to bedside. So you may have heard that term. But over the last decades, that's really been changed from bench to community. So NIH and others doing research have realized, certainly we've seen that with the COVID pandemic, that a lot of the barriers to health and healthcare aren't just from translating bench science to medications, but how these are applied in the community, why some people are able to be healthier in their environments than other people, why people are exposed to different environments, and then why certain medications are used or not used by different communities. And so this is all part of the work of Spectrum. They have a fantastic new website, which includes sort of access to our data, but a lot of other kind of training and resources. So thank you to Spectrum and Dean O'Hara for supporting these pilot grants in the area of population health research and community research. And thank you all for attending today. You know, over the past years, we've had great projects. This year was even more exceptional. And when we see this research being done and hear from the grantees, we really wanted this to be shared more broadly, people to learn from each other. So both, you know, if you're going through thinking about questions that you have, how this work relates to your own research, please ask questions or reach out to the researchers and vice versa. So, you know, this is kind of an introduction, and then also just really talking about this fantastic work that was done. We wish we could take you know, a whole day to do all of this, but really just want to give you a taste. So each of the talks is going to be 5 minutes long, lightning talks, just to give you a little bit of the flavor of the research, what some of the findings are. So please do let us know how this format works. We're curious to get feedback from you all, both from the presenters and grantees, as well as the audience, any suggestions going forward. But we're very excited about this. I'm excited to hear about the work that's been done over the past year. So please do put questions in the question and answer box. Since folks have about 5 minutes to present, they're probably not going to be answering questions during that 5-minute period of time. But as people then finish their talks, then they'll be able to answer questions. We'll also then have about a half hour at the end, so plenty of time at the end. So if you have questions you want, please write them down and remember them, and then we'll have a lot of time at the end for discussion. So with that, I'd like to get started, and I'd like to introduce our first speaker, who's Allison Kwong, who's an instructor in the Department of Medicine, Division of Gastroenterology and Hepatology. And she's going to be talking today about access to subspecialty care for alcohol-associated liver disease. Welcome and thank you.
All right, cool. So I will get us started off, hopefully, and stay on time with these quick talks. So my project was access to subspecialty care for alcohol-associated liver disease. And the background is, this is my entire research program. Focuses on alcohol-associated liver disease. It's now the leading cause of liver, well, it has been the leading cause of liver-related mortality worldwide, and is now actually, in the past few years, has become the #1 reason we do liver transplant in the United States. And that's because we've had just an increasing burden of liver disease related to alcohol in the United States, particularly during the pandemic, and among younger age groups, women, and the socioeconomically disadvantaged. And there are data to show that these patients benefit from subspecialty care, both in the form of gastroenterology and hepatology services, as well as alcohol use treatment. And then that this reduces the incidence of adverse or bad hepatic outcomes and improved survival. So the premise of this project was that we felt there were very likely gender, sociodemographic, and geographic disparities in access to this type of subspecialty care, and that we wanted to see exactly how those factors played into the differences in follow-up rates. So this was the setup, was that we would see how these variables lead to different rates in follow-up care, specifically after someone left the hospital, meaning they were very sick with alcohol-related liver disease, and how did they see these these services in the outpatient setting within 6 months? An arbitrary but seemingly reasonable time frame. And we used the Optum database, which is available through has been available through PHS, de-identified claims data from largely commercial payers and some Medicare Advantage over the past 20 years. So very quickly, the basic findings, we went from the 26 million hospitalizations in the database, about 85,000 had some form of alcohol-related liver disease by ICD-9 or 10 code. Most of them survived the hospitalization enough to have claims or office visits within the first 6 months of discharge, meaning they were available for follow-up. But there were really, just based on the surface, very few or suboptimal rates of follow-up. It should be 100% that really see a gastroenterologist, or and a majority that should have treatment for alcohol use disorder in the form of psychiatry, therapy, rehab, even just counseling. But as far as claims go, only about half were seeing GI, and maybe even less than 10% were accessing any kind of substance use treatment. So even on overall, it just we observed just suboptimal rates. The geographic distribution, this was just to show, this is by census tract, that it was fairly distributed. And these were the analyses showing that the first screen here is for GI, the next one will be for mental health services. So for the results were fairly similar, were that younger age patients were more likely to follow up. Men were less likely, Black and Hispanic race less likely. I had put in decompensation to represent the severity of liver disease, and those patients definitely did follow up more, or were referred more, higher education levels. And then setting the Pacific region as a reference range, actually we were the lowest rate. Every other region had a much higher rate of follow-up, or more like higher odds of follow-up with GI. And then mental health was similar, although there were some interesting differences. The geographic differences were not as pronounced. That would be the main thing, and no gender differences. So the implications, we discussed the findings. I thought the geographic differences in the GI analysis were the most striking. At least that they were most predictive of a follow-up, more so than the socioeconomic or demographic factors. So this work really would help us target future community level or regional interventions to improve referral and access to care, both at the patient level, are they not following up, or the provider level, are they not referring, and targeting who should benefit from, or who would benefit from more education in who to refer and who needs treatment for alcohol use disorder. So I'm hoping this work inspires kind of more, I'm hoping to get into implementation science and understand what interventions will improve referral rates. Is it that it should be done in primary care or in the hospital, or what we do in outreach, which is we go out to these clinics out in especially places with no gastroenterologists, like Nevada and New Mexico, is that what's needed? So things that help understand where the needs are. And then since we did identify some pretty interesting disparities, that additional funding to further develop this part of the work will be really interesting. And then part of this work also supported my K-23, which I did get during this funding period. So it was very helpful to that to study outcomes in alcohol-associated liver disease. So obviously I'd like to thank PHS and Spectrum, Dina, who one of the medical students who helped me with these analysis and to run Optum, and obviously my division and the Department of Medicine. Thank you.
Thank you, Allison. Thanks so much. And congratulations on the K. I didn't know that. That's awesome news.
Oh, well, yeah, well, the program was helpful. I mean, the data that came from this really went directly to that. So that's
great.
Thank you.
And hopefully we can continue to find access to Optum for you. But I'd also love to talk to you about the primary care data that we have, the EHR primary care data, which may be really interesting to look at for some of these in that population.
Yeah, that'd be great. Thank you.
Thank you. So next, I'd like to introduce Robert Fairchild. He's an assistant clinical professor in the Department of Medicine, Division of Immunology. He's going to be speaking on assessing disparities and clinician implicit bias in the use of biological therapies to treat rheumatoid arthritis. Thank you.
All right, thank you. I'm going to go ahead and share my screen here. Just give me a moment. All right, hopefully you're able to see that. Okay, so I'm going to talk to you about this project that I co-led along with Dr. Samard in the epidemiology and population health. So this project sort of spanned two different goals. So just to give you the background on it, rheumatoid arthritis, it affects roughly 1% of the population. It's associated with significant functional disability and early mortality. And about 10 to 15 years ago, biologic disease modifying anti-rheumatic drugs, biologic DMARDs, many are probably familiar with Humira, Enbrel, et cetera, came along and really showed an improvement in quality of life, reduced radiographic progression, decreased joint damage, an improvement in clinical symptoms, less pain, functional disability, and swelling. The downside of biologic DMARDs is that they're costly. That's why we were all seeing commercials for them on TV all the time. They're more immunosuppressive. They require self-injection or infusion compared to traditional oral therapies. So prior studies have shown that minorities are disproportionately affected by rheumatoid arthritis with more pain and disability. Minorities are prescribed biologic DMARDs around 50% less often than whites. The decision to start a biologic DMARD in rheumatoid arthritis, it's important to understand that it's related to a variety of factors. And this includes provider and patient attitudes, disease severity, comorbidities, and of course, cost and insured. So our hypothesis is that racial and ethnic disparities in biologic DMARD use in rheumatoid arthritis exist, and they may be associated with insured type and provider biases. And so to assess that, we sort of went in two different directions. One was to really look into our academic medical centers' patient records over the last over a period of 3 years, and really assess biologic prescriptive behavior by providers and look for associations and disparities. So the way that we did this was that we extracted Stanford medical record data from the STAR database, using this criteria with unique patients with Stanford rheumatology visits between 2016 and 2019, age 18 and older, with RA-associated ICD-10 codes. And then we also reviewed them manually to make sure the diagnoses were accurate. Race and ethnicity was grouped by non-Hispanic white, non-Hispanic Black, and Hispanic. And then data extraction occurred from the index visit, which was the most recent rheumatology visit within the time window above. So the types of variables, this was actually took quite a bit of work, because you can imagine these variables, a lot of them are not unstructured. And so you actually have to go through the note and kind of extract out these different things. Demographics, insurance type, current and prior medication use and prescription, disease duration, important labs such as RF and CCP, which are labs that are markers of rheumatoid arthritis, contraindications to therapy, and reason for therapy discontinuation. And so the very first thing that roadblock we ran up against was that in that window for unique patients, there were only 34 African Americans and so we basically included all of them. There were, in addition, we collected 50 white and 50 Hispanic. The conclusions, it was quite limited in terms of numbers, but again, it took quite a bit of work to actually get through these records. Joint pain and swelling were significantly more severe in Blacks and Hispanics compared to whites. And similar findings were seen when you stratified by biologic, DMARD, ever or never prescribed. So really across the board, Blacks and Hispanics seem to be both reporting and were showing increased evidence of inflammatory arthritis and increased severity. And then Blacks and Hispanics appeared less likely to ever have been prescribed biologic DMARDs, although this was non-significant, again, because of powering issues. But as you can see, 66% of whites, 56% of Blacks, and 58% of Hispanics. While having private insurance was significantly different among the groups, 60% of whites, 26% of Blacks, and 50% of Hispanics, this didn't appear to be associated with biologic DMARD prescription behavior. So it seems like, there are these potential disparities. There's certainly disparities in symptomatology. And then the question becomes, why this might be. This sort of leads into AIM-2, which is we also were interested in looking at the potential for implicit bias by clinicians in the prescription of these medications. And the way we went about doing that was a Qualtrics survey using 5 clinical vignettes with multiple choice responses. And so this is kind of the typical questions you would get for a board exam or something similar to that. And then you randomize race and ethnicity across the questions. The study population is US rheumatologists. And then we've completed a pilot testing thus far, and Stanford rheumatologists and are about to send out to this national list of roughly 3,000 US rheumatologists with an incentive for participation of $20. So what this looks like, these are the questions. And so we've gone over iterations of this many times to try to perfect these. But the idea is that you randomize the race and ethnicity. In this case, you're seeing Hispanic here, but the same question could be asked with Black or white in the head. And the idea is to try to flesh out whether people will respond differentially to the question. And the questions are sort of built to be, right on the border of deciding whether or not you would want to start a biologic therapy or not. So that maybe that implicit bias might push you one way or the other. So this is a sample of the question. And then, so we've done this pilot testing, the randomization works, incentive works. And we've tested the rheumatologist mailing list and individualized links. We demonstrated feasibility, and in this single academic center, there was a little variability in the prescribing patterns by race, again, very small sample. And we're about to distribute this nationally once we finish getting the feedback and sort of tweak this survey a little bit more. So just to wrap up here, the implications for AIM-1, we're considering expanding the study population, focusing on Hispanics and whites, given that within Stanford, there are definitely more patients that we could look at and may be able to further power the study. In addition to that, in parallel, is consider pursuing funding for VA study expansion. And then for AIM-2, send this out for this national survey nationally. And then thinking about, if this implicit bias survey does demonstrate biases in prescriptive behavior, can this help inform future qualitative work to help contextualize the findings and explore potential reasons for that? With that, I'll take any questions.
Awesome. So please, thank you so much. This was fantastic. It's wow, a lot of work on that AIM-2 and refining that, but the results from that kind of paradigm in those studies are so important and so powerful. So it's great to see. So yeah, put questions in the chat, and then we'll also have time afterwards. So next, I'd like to introduce Jackie Ferguson, who's a PhD research health science specialist now at the Center for Innovation to Implementation at the VA Palo Alto Healthcare System. She's going to be speaking on examining the use of virtual and video care following the rapid expansion of virtual care in the VA. Very timely and important topic. Thank you, Jackie.
Thanks so much, David. So I'll jump on in. Essentially, a rapid expansion of virtual care was central to VA's national response to the COVID-19 pandemic. And despite the potential for virtual care to maintain healthcare access, a rapid transition could exacerbate technology access disparities known as the digital divide. So here I've presented a figure that details the proportion of each veterans age group, those 18 to 44, those 45 to 64, and those 65 plus that had at least one video visit in each month. So prior to the pandemic starting, about 3.2% of veterans aged 14 or 18 to 44 had at least one outpatient video encounter in a month. But as we move through the pandemic, about 1 year in, about 12% of those veterans had an outpatient video encounter in a month. Well, in comparison, older veterans, those aged more than 65 years, only 1% of them had a video encounter prior to the pandemic starting, while in February 2021, that had increased to 4.5%. And this is a really great visualization of what we call the digital divide. Even though there was a relatively larger increase in the percentage of older veterans using outpatient video encounters, there's still quite a noticeable gap between them and younger veterans. And so this was what we were aiming to evaluate in this grant, specifically thinking about, are there differences in the frequency of video care use among veterans? And ultimately, are there differences in the type of care provided? When we think about a rapid transition, veterans who are dependent on in-person care could suddenly find themselves unable to access VA healthcare services. So given these rapid transitions, we wanted to evaluate these frequency of use among veterans. For example, are older veterans using mental health care, primary care, specialty care at similar rates as younger veterans? Our methods focused on using a retrospective cohort analysis of 4.5 million veterans who are active in VA care. We use data from the VA corporate warehouse, which is a repository for the data from VA electronic health records. And we followed veterans for their first year of the COVID-19 pandemic for their utilization of video-based care, whether that was primary, mental health, or specialty care. We adjusted for a number of confounders, including patient demographics, history of care provided at VA, and the VA Medical Center. To jump into some results, we found differences in the rate of video care utilization by sex, age, rural and urban status, number of chronic conditions, and the presence of a mental health condition. Most notably, we found that older veterans had a lower rate of using all types of video care compared to younger veterans, and that rural and highly rural veterans had lower rates of all types of video care compared to veterans living in urban locations. In models that were stratified by care type, we also found differences in the use among veterans with a history of homelessness and veterans who are identified as low income. Most notably, among veterans who are enrolled with VA without special considerations, low-income veterans had slightly lower rates of primary care use, but slightly higher rates of mental health and specialty care use, indicating that there's a difference in how low-income veterans are accessing care in VA. Additionally, another population of interest with VA, homeless veterans, we found differences among them. Despite having lower rates of primary and specialty care use, veterans with a history of homelessness had a higher overall rate of mental health care services compared to veterans without a history of homelessness. So our next steps for this work, I'm very pleased to announce that this work funded by the Spectrum Pilot Grant was successfully used to garner more funding from VA, which will support me over the next couple of years as I examine the proportion of video care that veterans are using in the VA, as well as evaluating an intervention program to address the digital divide among veterans. Even though we're seeing differences among veterans uptake in virtual care, we can't tell quite if it's a disparity, that it's something that we need to fix, or if it's a preference. Like maybe it's okay that older veterans aren't using as much video care as younger veterans if they're able to get more in-person care. So these next two evaluations will focus on that. And ultimately, the next steps for this whole research inquiry is to try to identify when video care can be a complement or a replacement of in-person care. As I demonstrate on this graph on the right here, video care is pretty much here to stay. We see a high proportion of it, even a year and a half into the pandemic. So my next steps will be looking at evaluating that further. A quick thank you to the collaborators, and thank you again to the PHS Spectrum Grants for funding this work.
Thank you, Jackie. It's fantastic. Appreciate it. Next, we will have, let's see, looking at my list. I'd like to, so please put in questions for Jackie, but then we'll come back to more questions later if we, at the end. Next, I'd like to introduce Zhang Huang, a PhD student in the Department of Economics. He's going to be talking about Florida pill mills and the US heroin epidemic. Thank you.
Great. Thanks so much, David. Sorry. Great. So my project is going to be about Florida pill mills and their relationship to the US heroin epidemic. And so the US is in the midst of an opioid crisis. This is a graph of opioid overdose deaths by the National Center for Health Statistics. And the opioid crisis is commonly characterized in two waves. The first is sort of this part, which started in the late 1990s when the medical community began advocating to treat pain as a fifth vital sign. And so this, combined with marketing campaigns by pharmaceutical companies, led to a widespread prescribing of prescription opioids, which led to a dramatic increase in prescription opioid deaths. And so the second wave, and sort of the one that policymakers have really focused on recently, started in 2010, where deaths from illicit opioids like heroin and illicitly manufactured fentanyl have skyrocketed after years of remaining stable. And so because this has been such a point of concern, I'm going to be looking at market and policy factors that explain this transition from prescription opioids to illicit opioids. And so the first part of my project is going to look at the OxyContin reformulation. And so for some background context, a very popular hypothesis in the literature is that the introduction of abuse deterrent OxyContin, which is a popular brand name version of oxycodone, is what started the heroin epidemic. And so in August 2010, Purdue Pharma, who is the manufacturer of OxyContin, switched the formulation of OxyContin to make it more difficult to abuse. And it was the first drug to ever receive an abuse deterrent label from the FDA. And so I'm actually going to argue that the OxyContin reformulation didn't cause the heroin epidemic. And so the first sort of evidence for this is that, OxyContin was really only a small fraction of the opioid pain relief market prior to reformulation. And so here, when measuring market size, I'm going to be measuring everything in morphine milligram equivalent, which is just a way to standardize dosage across opioids. And so this dashed line here refers to the OxyContin reformulation. And we can see that OxyContin was less than a fifth of sort of the prescription opioid market share, prior to 2010. And the main sort of explanation for this is that oxycodone IR, which is sort of a generic oxycodone, was much cheaper and extremely popular. And so, just based on market size alone, there was really only so much impact that the OxyContin reformulation could have, given that patients could, or abusers could, just substitute to generic oxycodone. And so comparing deaths in states with sort of above and below pre-reformulation exposure to OxyContin, and here exposure is just, sort of per capita usage of OxyContin, we can see that they both skyrocketed after the OxyContin reformulation. And so the reformulation alone really can't explain that transition to heroin. And so instead, what I'm going to be arguing is that the closure of Florida pill mills is what catalyzed substitution to heroin. And so for some context, pill mills here are referring to pain management clinics in Florida that were extremely prevalent, and they were extremely lax with sort of their prescribing. And as a result, they were a common source of oxycodone for the black market. And so Florida was the epicenter of the opioid crisis until interventions that began in mid-2010. And so at the peak of the problem, a fifth of all oxycodone in the nation was being sold in Florida. And out of 100 of the top doctors prescribing oxycodone, 98 were located in Florida. And so a few things from this graph. So here, these dashed lines are going to be referring to interventions in Florida, which I won't get into much detail, but we can see that, there was a sort of large spike in generic oxycodone distribution in Florida prior to these interventions, and then there was a large decline after the interventions. And so why Florida pill mills mattered were because Florida pill mills were a major source of black market oxycodone for the eastern US. And so famously, Interstate 75 was referred to as sort of the Oxy Express. Here, and you can see that, Senator Sherrod Brown was essentially telling the Florida governor that he needed to do something about this Oxy Express and how all of these drugs were going to the east coast of the US. And so naturally, that sort of presents this quasi-experimental setup where we can compare states east of the Mississippi River to states west of the Mississippi River. And we can see that conveniently sort of right after the closure of Florida pill mills, we see this large spike in heroin deaths for states east of the Mississippi River that we don't really see for states west of the Mississippi River. And so in the paper, I do I do more in-depth analysis and sort of different kinds of ways to control for confounding factors, but this is just sort of stylized descriptive evidence. And so another way that, to test this hypothesis further is I'm actually going to be looking at counties that are more socially connected to Florida versus counties that are less socially connected to Florida, using sort of the Facebook social connectedness index. And here the reason why that we think that's a good proxy is because, previous economic research has shown that social connectedness is highly predictive of trade flows. And this is particularly relevant for Black market drugs because they rely on sort of ethnic and kinship networks in order to sort of trade. And so here we can see that on the East Coast, counties that were socially connected to Florida saw much higher rise in heroin deaths than counties that were less socially connected to Florida. Whereas in the West Coast, where there wasn't any sort of diversion from Florida pill mills, we don't see that sort of effect. And so here, this sort of difference in difference suggests that the Florida pill mills were a big component in terms of that substitution to heroin, and that the heroin epidemic was likely catalyzed by the closure of Florida pill mills. In terms of policy implications, this demonstrates that drug markets are highly interconnected and that supply-side interventions alone are unlikely to end the opioid epidemic, and that we do need to think about investments in sort of demand-side interventions like medically assisted treatments. And so this research was sort of very integral in terms of helping me win a fellowship from the Robert Wood Johnson Foundation to further research drug markets. And thank you.
Thank you, Zong. Great to hear that. Great to hear. Congratulations on the fellowship. That's great news and really interesting to hear about this work. So I'm sure we'll have more questions here at the end for you. Great presentation. And now I'd like to introduce Matthew Lees, who's a PhD student in the Department of Geophysics. The topic is observing the health impacts of nitrate contaminated groundwater in California's San Joaquin Valley. Thank you.
Okay, thank you very much. So hi, everyone. I'm excited to be able to introduce you to a new project, actually, which recently sprung out of a Spectrum grant. And we're looking for associations between nitrating groundwater and health outcomes in California's San Joaquin Valley. And this project is between myself and Jenny Sakali from the School of Earth. So where is the San Joaquin Valley and why is it important? Well, here is an image of the valley. And it's shown as the grayed region in the map on the right here. The most significant thing for this talk about the valley is that despite containing only approximately 1% of US farmland, it actually produces a massive 5 to 10% of US agricultural output by value, which equates to about a $25 billion annual output. So clearly this is an extremely intense agricultural industry being hosted in the valley. Unfortunately, one consequence of this is that there's a lot of concern regarding pollution, certainly for the communities. And this becomes very apparent when you see images like this, very typical of the San Joaquin Valley, where communities butt right up against the agricultural land. So in this project, we're focusing on nitrate contamination of groundwater. And nitrate gets into groundwater from agriculture in two primary ways. It comes from fertilizers and also animal waste. And unfortunately, it's been well documented that this has indeed infiltrated into the groundwater in the San Joaquin Valley. One of the reasons this is particularly concerning is approximately 90% of the residents in the valley use groundwater as their primary resource. So we're focusing on the health impacts of this contamination. And what motivated us to explore this problem? Well, first of all, during a literature review, we were surprised to discover only 3 papers which were exploring the issue. And none of them had access or were using the high quality health data that we had access to through PHS. And secondly, we had a sort of policy inspired motivation, which was that we hoped that a little more detailed investigation of the health outcomes could lead to more targeted policy in the future, potentially targeting remediation and monitoring efforts. So our approach is to use these 2 data sets. The first is the Optum ZIP5 dataset from PHS. This was introduced in one of the previous talks, but it is a record of over 9 billion health insurance claims from both commercial and Medicare providers. And these claims are tagged with the zip code in which the code was in which the claim was made. And our approach is just to simply use an observational comparison of these health insurance claims with information about the groundwater quality, which comes from the Gamma California Groundwater Quality Network. So although this is a new project and the work's still fairly early, I'm going to show you a few of our preliminary findings from exploring these 2 data sets. And the first place we started was to look at methemoglobinemia, which is also known as blue baby syndrome. And this is a condition out of all conditions with probably the best established link to nitrate exposure. So it was the obvious place for us to start. However, it actually led to finding of a null result, essentially. And that's shown on this slide. Here I'm plotting the instance of blue baby syndrome in the Optum data in the US as a whole, California, and then the San Joaquin Valley. And you can actually see that it is less prevalent in the San Joaquin Valley than either California or the US as a whole. So this is good news for the inhabitants of the San Joaquin Valley. However, this is a pretty rare condition, and actually this represents fewer than 20 individuals. So this wasn't really a conducive avenue for further investigation. So the next approach we took was to consider gastroenteritis. It's a far more common condition, although it is less specific in its link to nitrate consumption. And investigating this, we were able to explore the spatial patterns of it in a bit more detail. So we started with the groundwater data shown on the left here, and we simply categorized it by the zip codes to high, moderate, or low exposure, where high exposure refers to a location where EPA standards have been breached, which means it's meant to be harmful for human health. And then we compare this with the Optum data. So here we have the number of cases reported in the Optum data, which we've normalized by population to create this map on the right. And we can see that the incidence is relatively low in most places, apart from up here in the north, where you have approximately as many as 1 in 5 individuals have made a claim for gastroenteritis. And this has led us to one kind of interesting area which leaps out in the valley. This is the Modesto-Turlock area, which is where we have the high incidence of gastroenteritis. And it's correlated with an location with high nitrate exposure. However, it's not unique in that respect, by which I mean there are many other areas in the valley with high nitrate exposure which do not see the spike in gastroenteritis cases. And that's the situation we're currently at in our research. So we're next looking to explore why this might be, if there's anything unique about this area. In particular, we're looking to see if there's more exposure that the water actually gets into people's bodies more readily, and also whether socioeconomic disparities might explain some of these differences. So the conclusion so far is that we certainly think the Optum data can be applied to explore incidents of health impacts due to nitrate ingestion. And there are some complex patterns in the data which we're currently exploring. And I'd like to thank the people on the slide here. Thanks for your attention.
Thank you, Matt. Great presentation, really interesting. I'll be curious to see what you find is going on up in that region. Next, I'd like to introduce Cesar Vargas Nunez, who's a PhD candidate in the Department of Political Science. And he's going to be talking today about navigating healthcare exclusion as an undocumented immigrant, evidence from Facebook. Cesar.
Thank you, Professor Rakoff. Super excited to be here sharing some of my ongoing work with you guys. So I'll start with the motivation for this project, and that is that despite the need, undocumented immigrants remain excluded from most government welfare programs, including government healthcare. And what this means is that for undocumented immigrants who fall ill, they are placed in a difficult position whether they must choose to postpone needed medical care or risk financial ruin and a potential deportation. This situation was worsened by the COVID-19 pandemic that has amplified existing healthcare inequities, because not only are undocumented immigrants in the position that I outlined earlier, but now they're also in the front lines of the pandemic in industries with high risk of contracting COVID. So this produces worsening health for not only undocumented immigrants, but also their families and their communities. So this leads me to my two research questions, which are, how have undocumented immigrants navigated the COVID-19 pandemic, living with this exclusion? And to what extent have undocumented immigrants been able to access COVID-19 testing and medical care? Before I dive into the methods and results, I want to highlight the difficulty of being able to collect evidence directly from undocumented immigrants, and that's because we have a eligibility problem. For clear reasons, undocumented immigrants are not a group that's known to want to be in the spotlight, and previous scholars have had difficulty in being able to collect evidence directly from these individuals. So the focus so far has been on small and qualitative studies or proxies using large administrative data sets, each with its own limitations about speed of collecting data and also inference about the status of these individuals. How do I overcome this obstacle? Well, I use targeted Facebook ads to try and recruit a data set of likely undocumented immigrants to collect evidence directly from these individuals about the ways that they navigated the pandemic and to what extent they were able to access medical care. So what I use is a Facebook targeted ad manager to send ads to individuals who meet a certain criteria, and that criteria is that they must be adults, must have their Facebook set to Spanish, must be away from their hometown, and must have lived in Latin America at some point in their lives. And happy to talk in the Q&A about what each of these means in practice. So here's a snippet of what it looks like on the right. The ad kind of showed up on user's timeline. It had a small quote in Spanish: complete this quick survey of 5 minutes to help us understand the impact of COVID-19 in our communities. No political bent, no kind of bias there. And then that leads them to a secure Stanford Qualtrics account where they can answer the questionnaire. The ad campaign lasted about 2 months, and the targeting was initially heavily focused on states with large immigrant presence, such as California and Texas. Roughly 1,100 individuals began the questionnaire. About a quarter of them did not complete, but we have a data from almost 719 of them. This is what the data looks like for the sample descriptives, with most individuals being middle-aged Hispanic women with a high school education or less, and low socioeconomic income once you take into account household size. Most respondents were born abroad, not surprised given the targeting, and they came from California and Texas, and most of them also came over 10 years ago with a mean size of about 4 individuals per household. COVID impacted this population pretty heavily, with 40% of individuals noting at this point, this is March 2020, they had infection of COVID-19 at some point, which is much higher than the CDC estimates that as of November, where about 25% of the population in the US has contracted the virus. Half of the respondents had COVID-19 infection at home, and over 10% had a death within the home. Most individuals were able to get a test for COVID-19, which is encouraging, but a significant proportion of them had to travel over 10 miles to get that test. It will be very interesting to see now with the emergence of rapid tests how this may vary, but at the time it seemed that these tests were very difficult to find for some folks. Now, to what extent was I successful in kind of really digging into this population of interest? To investigate this and to see variance across likely undocumented immigration status, I built an index that takes into account 3 categories. The first is birthplace. So if they were born outside of the US, they get a 1. If they are worried about ICE in their community, they get a 1. And the last one is healthcare access, which takes a combination of income and also healthcare coverage. So for example, individuals in California who are a family of 4 earning $20,000 and they say they're uninsured, or they get medication from friends traveling to Mexico, I label them as 1. The outcome is an undocumented index, with 0 being not likely undocumented, 3 what I consider likely undocumented. Here you can see the breakdown. Most folks fall within 1 to 2. And let's look now at the differences in COVID-19 infection at home by this undocumented index, which is what I call it. And what you see is that as the risk of being undocumented increases, the presence of COVID at home also increases significantly, where by the three panel here, it's actually higher yes than no. So to summarize, I was able to use Facebook ads to target likely undocumented immigrants and collect direct evidence from them about to what extent they were able to access COVID-19 medical care. There's some important limitations, which is that there's a convenient sample, immigration status is not 100% identified, and that there's many holes which individuals can fall on Facebook target. Happy to talk in the Q&A about running ads on Facebook. But there's important implications. One is that this design can be replicated by other scholars who seek to recruit hard to find communities, but also that this highlights the kind of dual vulnerability of healthcare exclusion and immigrant legal status that produces worse health outcomes and increased risk from COVID-19. And with that, I just want to acknowledge the support from Spectrum. This is just a snippet of the result. There's a lot more rich data that I don't have time to, I already gone over my time. But there's two more projects that I've been working with. One is the conditions under which citizens support expanding welfare access to undocumented immigrants. And the other one is characterizing the political and healthcare seeking behaviors of mixed status individuals. Thank you. And with that, I end my presentation.
Thank you so much, Cesar. Appreciate it. It's great to hear about this work. Next, I'd like to introduce Michelle Patel, a psychologist and researcher at the Stanford Prevention Research Center, Department of Medicine. And she's going to be talking about optimizing behavioral obesity treatment using digital health for racial ethnic minority populations. Thank you.
All right, great. Thank you for having me. And I'm excited to be able to conduct this study where I was combining my interests in obesity research and behavioral treatment strategies and digital health to conduct a pilot study. So we know obesity is highly prevalent in the US, and behavioral interventions are the first line treatment for obesity, where people work on improving healthy diet and promoting physical activity. Unfortunately, racial and ethnic minority populations who have disproportionately high rates of obesity are often underrepresented in these behavioral weight loss treatments. So there's a clear need for scalable and effective intervention strategies that can broaden reach and minimize the traditional barriers to enrolling in these behavioral obesity treatments. So I'm really interested in digital health strategies serving as a vehicle for these behavioral interventions. We know 85% of US adults own a smartphone. These devices are highly portable. They can help broaden reach and scalability of interventions and often have high acceptability if designed well. And one component that can be delivered via digital health is self-monitoring one's dietary intake. So this is a key component in behavioral obesity treatment, and it typically involves recording everything you're eating and drinking every day. So on the right-hand side of the screen, you can see an example where someone is tracking their milkshake that they ate in an app on their phone. So we know that self-monitoring one's diet is considered the most effective component of behavioral obesity treatment. However, engagement often declines over time for a variety of reasons I won't dig into in this particular talk. But because of these reasons, there is a need for a simplified version of self-monitoring. We need to test whether simplified versions can increase acceptability, feasibility, and efficacy of weight loss interventions. So one approach that I tested in my pilot study was providing a brief online survey to participants every day where they simply went through a checklist of unhealthier foods and drink options, and they would just simply check through that survey. And we compared that to the traditional form of detailed diet tracking where they're tracking everything they ate and drank every day. So the aims of my pilot study were to assess the degree to which our target population of those racial and ethnic minority groups were reached by our recruitment efforts, to assess the feasibility of those two self-monitoring approaches, the simplified approach versus the detailed approach, and to evaluate the acceptability of our intervention strategies and our different study procedures as shown. We conducted a 3-month weight loss study. Again, we tested those 2 weight loss programs. And we enrolled 38 participants in our pilot study, and it was a completely fully remote study. So the intervention was remote, recruitment strategies were remote, and assessment procedures were all remote. So in terms of self-monitoring in our intervention, we asked participants to track their dietary intake, their steps, and their body weight. Again, their dietary intake was either through the detailed version or the simplified version. Steps were tracked via Fitbit activity tracker we provided, and their weight was tracked via smart scale we provided. And importantly, we asked participants to track these every day for 12 weeks. We collected self-monitoring engagement data objectively using Fitbit's API. And our primary feasibility outcome was looking at the percentage of days one tracked their weight, their diet, and their steps. So we had a lot of interest in our study. Just really quickly, we enrolled 38 participants, and we ended up having 92% retention at 3 months. And we really wanted to look at this because we're hoping to conduct a larger clinical trial down the road. And we were able to recruit 10 participants per week. So we had a lot of quick interest, which was helpful. And here's just a snapshot of our participant characteristics. As you can see in the bottom left, 58% of our participants identified as Hispanic of any race. And in terms of our main feasibility outcomes, we looked at the mean number of days someone self-monitored their dietary intake over the 12-week intervention. So in the detailed diet tracking arm in blue, you can see they started at 4 days per week on average, down to a little less than 2 days by the end. And then the simplified diet tracking arm was higher. They had higher engagement rates over time. In terms of self-monitoring one's steps, they started about 5 days per week, down to 4 days in the detailed diet tracking arm, and slightly higher in the simplified diet tracking arm. And then in terms of self-monitoring one's body weight, about 4 days down to about 2 to 3 days, and then similar in the simplified diet tracking arm. Again, this was a pilot study, so we weren't statistically powered to compare these differences, but it gives us insight into potential trends and observations. So in terms of our aims, we were able to achieve appropriate recruitment of our target population. It looks like our engagement approaches and self-monitoring approaches were feasible, and it looks like our strategies were acceptable. So in terms of next steps, I plan to dive into the qualitative data and looking more into acceptability and feasibility of these approaches. I applied for an NIH Career Development Award to conduct a fully powered clinical trial, testing the unique impact of different self-monitoring strategies. And I hope to continue collaborating with Drs. Abby King and Lisa Goldman-Rosas, who will serve as mentors on that K Award. And I received a talk that I submitted was accepted. So I will present that at the Society of Behavioral Medicine in April, and I'll also prepare a manuscript. And I just want to thank Stanford for the funding, my SPARC study participants, and then my co-investigators. And I had a wonderful team of 7 undergraduates who served as research assistants for my study. And if you have further questions, feel free to email me or find me on Twitter. Thank you.
Thank you so much. That's interesting and impressive to recruit and analyze data and get folks within that period of time. So a lot of impressive work. Thank you. So now I'd like to go to Nina Prabhu, graduate student in the Department of Management Science and Engineering, along with Pablo Paredes, a clinical assistant professor in the Department of Psychiatry and Behavioral Science, and by courtesy, Department of Epidemiology and Population Health. And they'll be presenting on personalized long-term stress management for at-home work, something we know a bit about, or at least the at-home work part, but we'll learn about stress management. Thank you.
All right, well, thank you. I'm Pablo, and Nina, you can.
Yeah, hi, I'm Nina. Good to see everyone. Okay.
All right, so let me try to share this thing, right? Okay, is this working? Can you see the slideshow well?
Yeah, you're good. Go ahead, Pablo.
All right, well, thank you for your time. We're presenting this project that involves a lot of people. Nina is one of the recent additions. Actually, many of the people here have already graduated or moved on to be like faculty somewhere. So some of the things that we will show here are still ongoing, but there's already some exciting results. So we basically developed this, let's call it plugin for Chrome, where people can actually access at any point this icon when you're working on your screen, and you can basically request an intervention for stress management. And the interventions have different, like, simple things that you can do that are easy to do. Like in this case, for example, you can go and translate something to get you distracted from your stress, or learn to translate something, or to a new word in a different language. You rate what you do, and you can get like as many interventions as you want across the different things that you do when you're feeling stressed. So the design of the interventions is based on this notion of just-in-time interventions. That's things that you can do just when you're feeling stressed. It's not something that you do at the end of the day. And we basically used 4 different categories of stress interventions: positive psychology, cognitive behavioral, somatic, metacognitive, to cover the entire realm of therapeutic options for people. And then our hope is that we can use algorithms to learn which of these work better for people. These are some examples of like the cognitive behavioral interventions that you can do. You can basically write people good notes, or just have like interesting ideas that you can do, take a quick stretch, etc. So these are designed to be very short, like 1 to 3 minutes of time. And again, you can do it as many times as you want. We basically wanted to create the interventions that people would be interested. So we went over a period of like design, where first we created different interventions, and then we got feedback from users. We reduced some of the interventions that didn't work, and keep refining. And eventually we ended up with like 160 interventions across all the different techniques that can be covered over all these 4 different broad fields of stress management, as you can see here. So we use this basically as our, what we call intervention library, to then train the algorithms. Our research plan evolved by, as I said, some pilot studies, and we started doing longitudinal studies. The first one started now in November, December, and we already have some data I will share with you. And we're about to run the second study, which will basically include the full-blown algorithmic approach that Nina has been working on, and she will tell you a bit more about that. And hopefully later this year, we will launch this as a Chrome plugin that anybody in the world can actually download and work and use whenever they need, when they are working in their computers. So the longitudinal study that we just collected data over 4 weeks and 41 participants. We generated almost 2,000 interventions, people requesting interventions. Many of them completed them, some people didn't. And there was a huge variation from a person who only requested 1 over the period of 4 weeks versus somebody who requested up to 66 of them over a period of 4 weeks. As you can see, there's a decline on the use of them. And this is actually something that we hope that algorithms will address over time, not just the efficacy, but also the adherence of these microinterventions. And the way to do that, the way to start learning how to do that, is by looking at not only traditional participant data like promise data or references or demographics, but we're more interested in passive data. We're trying to basically see if we can predict what interventions will work better just using the way that you click or the way that you move your mouse. There's prior research that I've been publishing on this field, so we know that there's a correlation between those fields and those features and your stress and interventions. Overall, the interventions did produce a stress mitigation, and majority of them reduced stress, or people reported that they reduced stress at the end of the intervention. Some of them had no effect, so basically were innocuous, and there was a small percentage where that people actually didn't felt actually more stress after doing the intervention. This is something that we're actually taking to understand why would that be the case. As you can see, there's majority. We had a scale from -2 to +2 on the change of stress, from 0 meaning like no change, and +2 meaning a lot of change, 1 just a little bit of change. You can see the histograms here. And across the different categories, there's a pretty good similarity. Somatic tends to be a bit more well regarded, and we've observed this in the past, like asking people to move or stretch or do some kind of breathing. It's actually something that people prefer. I'll let Nina explain this part of the simulation of the bandit.
Yeah, so we performed an offline policy evaluation to kind of simulate how a bandit would do versus random recommendations for interventions, which is what we're currently using for majority of our recommendations. And so as part of this, we simulated 3 multi-arm bandits. And so multi-arm bandits are machine learning models that I would think of almost like, they're called multi-arm because think of like pulling an arm of a slot machine. Like, would you rather, sit at a slot machine and pull an arm that has a pretty reliable chance of making you a little bit of money, or something that's maybe a bit more risky, that could make you a lot of money, but you could also just not make any money and then walk away having lost money overall. And so these 3 bandits have different like exploration versus exploitation parameters. And so exploration is kind of how risky is a bandit, like how likely is it to recommend a new intervention or something that, hasn't been explored as much by our existing participants. And so this could lead to kind of, showing a participant an intervention that they've never seen before and end up really liking, or it could have the effect where, it could be one of those rare interventions that a participant actually doesn't like and or feels like it, increases their stress levels. And so like another negative of this is that it could potentially, make a participant turn away from HSO, which is something that we're trying to avoid. But on the other side, we could, the bandit could choose to exploit its current knowledge. And so just recommend an intervention that, it knows does well. And so this obviously has the benefit that a participant, knows something will work and is willing to do it over again, but could have the negative that a participant could be missing out on, looking at interventions that could be better for them, or they could get bored by doing the same kinds of interventions over and over again. So we ran some simulations here, bandits with different exploitation exploitation ratio parameters. So the higher parameters here, 0.5, are more risky bandits, some might say, than the 0.1 parameter. So we could see from our simulations that they all did better than the random method. So here we've graphed the cumulative stress reduction over different intervention recommendations. And we can see on the graph on the right that even multiple trials with the worst performing bandits, some might say, perform better than the random. And so this just kind of can lead us to the hypothesis that a multi-arm bandit does have a better cumulative stress reduction than random assignment, which is pretty promising for its use in HSO.
Great. So one last thing that we plan to do also with more data, and sorry, we're running out of time, is look at the features that we collect from passive data and do this kind of like our square scores to basically detect which features are really useful. This data doesn't belong to this study, it belongs to a prior study, but we're working on a similar analysis to make sure that we collect the real data that works for the bandits and not collect a bunch of things that might not be useful and consume energy and time and all these things. And this is something that's coming soon. So at the end, the implications for this kind of personalization is that we can do automatic segmentation to discover participants' preferences as opposed to this randomized or like, traditional, like asking people. We can explore predictors, as I said, of passive data that might be useful to like really do this kind of like recommendations. We can adapt perhaps even interventions and have like interventions adapt to some of the changes in the bandits. And finally, of course, we have to think about the ethics and privacy because we're collecting a lot of like passive data. So we're really doing surveillance and we have to really know how to manage that. We have actually a parallel research that we're doing on the ethics of collecting this kind of data for these kind of predictions. Yeah, we have the plans to like advance to the next study and do these evaluations and submit our work to Nature Human Behavior, and of course apply for some kind of like R01 to test the algorithms across multiple populations, teens, parents, singles, etc. Thank you so much. This was Home Sweet Office automatic segmentation for personalized home just-in-time interventions.
Awesome. Thank you both. Appreciate you sharing that, and good, interesting to see kind of behind the scenes how you developed this. I have the Habit Lab on my Chrome browser, so look forward to when you can introduce this to everyone. So last but not least here, if you notice, these are in alphabetical order. Marissa Reitzma, PhD student in the Department of Health Policy, who's going to speak on prioritizing effective interventions to eliminate disparities in COVID-19 outcomes among marginalized populations. And look forward to, we heard about some of your work earlier on at PHS, which we appreciated. So now look forward to hearing where you are now.
Great, thank you so much. Let me know if the slides aren't working properly, but before I start, I do want to highlight our study team, really, as well as our broader research groups and partner organizations, which are shown on the slide. As we've heard in prior talks, COVID-19 has disproportionately impacted Black, Indigenous, and Hispanic populations in the United States. And in this context, our project sought to identify drivers of disparities, as well as corresponding interventions that would potentially eliminate disparities that we've observed in COVID-19 outcomes. Without getting sort of too technical in the lightning talk, our work synthesized multiple streams of data. So we included data on COVID-19 testing cases, vaccinations, deaths, as well as demographic data and data on occupation and important housing characteristics. With the COVID-19 landscape really rapidly evolving, as we've all seen, from this period of no authorized vaccines to a period of now universal adult eligibility in just a matter of months, we moved to really quickly use these data to develop flexible decision analytic models that allowed us to project outcomes under different realistic policy scenarios. So our work included three parts, the first of which was an analysis of disparities in risks of exposure and COVID-19 outcomes in California that focused on the period prior to vaccine availability. And in this work, we partnered with the California Department of Public Health to construct a joint measure of exposure risk, which reflected both occupation and housing characteristics. And then we use this to analyze associations with COVID-19 outcomes at a very fine geographic level. And in this work, we found that despite a scale up in testing over time, there was a persistent positive correlation between exposure risks and test positivity. And we found the highest risk of exposure was concentrated among California's Hispanic population. We also found that there was lower testing rates in areas with the highest exposure risk, as well as areas with highest case rates. And together that suggests that what we've seen in terms of documented disparities in outcomes was actually likely an underestimate. And finally, our work provided evidence that supports efforts for community-based testing, paid sick leave, as well as additional support for safe isolation upon exposure or a positive test. And this work we published jointly with our colleagues at CDPH in Health Affairs in May. The second piece of work then involved modeling the impacts of age-based eligibility criteria on disparities in COVID-19 vaccinations and deaths. And this work was focused on the first few months of vaccine rollout when supply was quite limited. In this work, our models demonstrated that age-based eligibility criteria, which was widely used across states as vaccines were beginning to be rolled out in the context of really constrained supply, that choice conferred greater benefits for white populations. And those benefits and the disparities were compounded by additional access barriers that we found Black and Hispanic older adults faced. We then ran alternative policy scenarios, and this was through conversations with decision makers in California to show that prioritizing additional vaccine supply for disadvantaged areas is actually both a more equitable and a more efficient way to allocate vaccines compared to distribution of vaccines proportionate to the eligible population size. And lastly, in this work, we found that differences in age-specific mortality by race and ethnicity mean that even in the best case scenario, even allocating additional vaccine doses to disadvantaged areas, it's still very, very difficult to close gaps in benefits under an age-based prioritization scheme. But quickly, the landscape continued to change, and we moved from a period of restricted supply to a period of universal adult eligibility, again, in just a matter of months. And so we translated and shifted our model to then focus on vaccination scale up during the period of universal adult eligibility and working to continue monitoring equity of rollout in this phase. So a major issue was that there's widely heterogeneous reporting of vaccinations by race ethnicity that hindered a lot of efforts to monitor equity in vaccine rollout. And so what we did was we developed an approach to apply very consistent and transparent rules and then reconcile these heterogeneous and sort of missing data to explicitly quantify vaccination disparities for all states in the US over time. This work documented the impacts of access barriers pretty clearly, which resulted in persistently lower vaccination rates among Black and Hispanic populations, even after we controlled for the effects of age-based eligibility criteria. And then we modeled different potential coverage scenarios to demonstrate, again, the benefits of place-based targeting of efforts to promote vaccination uptake. And we use this to highlight the continued need for explicitly pro-equity policies in the COVID-19 pandemic response. And this sort of third piece of work was published in JAMA Network Open in October. In terms of our policy impact and continuing work, by demonstrating these strong benefits of place-based targeting to reduce disparities, our work helped to directly inform California's decision to allocate an additional 20% of their limited vaccination supply to the most disadvantaged quartile of zip codes sort of early on in scale up. And we continue to evolve our work as the pandemic evolves and vaccination eligibility changes. So we're currently focused on analyses of disparities in vaccination scale up among children. Thank you very much, and I look forward to your questions.
Thank you. And thanks everyone. These were just amazingly clear and interesting talks, and you know, all on just the most pressing kind of questions we have right now. And you know, from opioids to obesity to COVID, and then also all projects that you know, you can really see the translation, you can see the solutions coming from each of these projects. So really just super impressive and inspiring to hear. So I'll turn it now over to Alistair, moderate the QA. We have about 10 minutes or so for Q&A.
Great. Thank you, everyone. And thank you to all of our speakers. This is a fantastic group of presentations and work. So thank you so much. So we've got a few questions listed in the Q&A box. And again, if you have additional ones, now is the time to add them. The first question is going to be going to Jackie. So Jackie, one of our listeners has asked, do you see some deficiencies in the technology used, for example, Zoom, for the remote care of VA patients? So are there any observations with regards to the interactive features of the tools, and what is your wish list?
Well, I should probably start answering that question by saying I'm not a provider of video telehealth services. I just study the back end of it. But from our discussions with patients and providers at VA, I can give you a little bit of a contextual understanding of VA. So early on in the pandemic, when there was that really dramatic shift from in-person to virtual visits, there was a wave restriction to use kind of the HIPAA compliant video system. So there was video visits that were occurring on private video servers such as Facebook Messenger, Google, but the VA does have its own video telehealth platform known as VA Video Connect. And so that's the one that VA's been really strongly advocating because it's, tested, providers are trained on it. It does definitely have limitations. I think one of the questions parts of those questions that you're getting at is how easy do people find using the video technology? And there is some disconnect. Folks sign up for a video visit but aren't able to log on, or their internet communication isn't stable. So those video visits either may end up getting canceled, or they might end up being transferred over to telephone use. So we have some work ongoing right now, interviewing both patients and providers to see how we can better support and augment video-based communications within VA, and how we can help reduce the amount of disconnects and conversions from video to telehealth if we see video as being really the gold standard for telehealth-based communications. Fantastic. They have a long list of wish list items that we've been hearing about.
Great. Thank you so much for that response. Wonderful. So the next question is going to Matt. So the listener is interested in learning more about the methodology used to map OptumZip data to geographic level nitrate data. Can you speak briefly on this?
Yeah, absolutely. Thanks. It's a really good question, actually. It gets to kind of the crux of one of the issues we faced, which is that the Optum data is at a zip code level, whereas the nitrate data are actually point measurements made in individual wells. So it's kind of, how did we reconcile these two scales? And there's a lot of different things we could do in terms of approaching this. The approach we took was to set a threshold within each zip code. And if any well within the zip code measured greater than that threshold, we then put the whole zip code into a particular category. So we had a high, medium, and a low threshold. And part of you could take several different decisions. One of the benefits to taking this decision is that our general kind of conceptual model, which comes a bit from the literature, is that nitrate in groundwater is kind of progressively increasing over time. It kind of cumulatively builds up. So the idea being, if we have a variable network of monitoring wells measuring these things, if one of them detects above a threshold, it's likely representative of this gradual buildup. However, there's also some kind of finer scale spatial and temporal variabilities in nitrates that will occur in the groundwater system. So one of the worries is that we may be miscategorizing a few zip codes on the basis of one anomalously high measurement, which does not mean that the population are exposed. So this is something we're actually trying to look into a little more about some other approaches we might take. But for now, we're sticking with the thresholds as a first pass.
Fantastic. Great. Thank you so much. And I think we had a question from David. If you want to just jump in, David.
Yeah, I had a question for Robert on your sort of aim to paradigm, which I really like. I think, a lot of the most useful evidence is from, start my video. It comes from this paradigm. And I wonder, and it was great to see the response rate. I wonder how much you think people are kind of, as there's awareness of this paradigm, of these vignettes with different race, that people are becoming more and more aware of that and maybe kind of not answering as honestly. And so I don't know if there's anything you can do about that, or if you can, like, after you ask the questions, ask, did you know what we were getting at, or something like that.
Yeah, that's a great question, and it's a shame, unfortunately, Julia Smard couldn't be here because this is actually her main focus. And I know she's done this in other studies previously. And I will just say, just anecdotally from my perspective, up until last year, I hadn't heard about this approach. I have received these kinds of things in the past personally, and my suspicion is that, just thinking among rheumatologists, I know now in our division, rheumatologists are aware of it because Julia has presented to our division on this topic. So I wouldn't be surprised if everyone recognized immediately, oh, why is Hispanic right at the first line. But I don't honestly have the answer. I think, some of these kind of like balancing measures you're talking about whether you can understand, we could measure whether or not after people have answered the questions, whether they're recognizing that. I think that's a great point. But the way they're being presented these questions obviously is they're just seeing for questions that happen to have these labels on them and sort of nothing else. So I don't have a perfect answer for it. I think it's an interesting question. And I think I'd have to get back to you. I'd ask Julie. I'm sure she would know more about that than I would. Yeah.
Great, thanks.
Thanks so much, Rob. Okay, and the last question goes to Caesar. So Caesar, this is actually my question. I was surprised to see the response level that you got through the Facebook ad. It was higher than I was expecting. I see those Facebook ads and I usually disregard them. But I was curious, what were the pros and cons with that recruitment approach that you found? And did you consider any other non-Facebook recruitment approaches?
Hi, yeah, that's a great question because it kind of gets at the perks and the drawbacks of using social media as a recruitment tool. So the sample it is what it is, but it doesn't. I didn't include that it had over 500,000 impressions. So that means that at some point, not 500 individual users, but 500,000 times the ad was shown on a screen. And that Facebook kind of has like a black box about how it determines its best utilization of ads based on the targeting strategy and the amount of money that you're willing to pay them. I did think of other recruitment tools like partnering with organizations and kind of doing a little bit more snowball sampling. I think the reason why I shied away from that is that in order to large scale something like that, it's a little bit difficult because you need to have the network and the connections. And I wanted to be able to test the waters with hard to reach populations in the US with folks who are both vulnerable given their background, but their legal status. And to what extent can we also let other scholars follow similar approaches to answer different questions? So hopefully I've kind of tested the rough waters first, and this kind of lead other folks to follow similar approaches, and then we can all contribute to understanding more about the ways that they navigate living in a society where they're excluded and also vulnerable to immigration enforcement.
Great, thank you so much. Wonderful. Well, thank you for everything. Everyone has done a fantastic job. I'm going to hand the floor back to David to finish off. David.
Yeah, just thank everyone again. This was fantastic. And I'll just end by advertising that we're going to be doing another round of Spectrum PHS Pilot Grants that will open up in February. They'll be due March 31st. We'll have an info session on February 28th, 1:30 to 3. It's going to be very similar as last time, really focused on health inequalities and really impactful research. So look forward to those in the audience and the speakers, applying again and proposing more great work. So thank you all very much. Appreciate it.